This is part 11 of a step-by-step vitrectomy. We will start to talk about macular hole surgeries. In this part, we will talk about standard complete ILM peeling. The most critical and the most important step in doing ILM peeling in macular hole surgeries is to initiate the ILM peeling. We can initiate ILM peeling with one of three methods. The first one is to do pinch and peel technique. Pinch and peel technique is done with the forceps, with the end gripping forceps, starting to pinch the retina to initiate a flap, then completion of ILM peeling. The second method is to use the tin scrubber, the diamond dusted tin scrubber. The third one is to do peeling with the help of flex loop, initiating the ILM peeling and then completion with the forceps. These are the steps for standard traditional ILM peeling technique. First of all, we have to know where is the site where we can initiate the ILM peeling. It is well known that the thickest part of the ILM is lying beside the large vessels, so we can initiate ILM peeling at this site. But the problem in this site is it is far away from the center of the fovea. So we can choose to make peeling midway between the center of the fovea, where is the hole, and the arcades. This helps us to move just a few steps to reach the center of the fovea. When we are using a forceps, first of all, we have to close the forceps slightly before going down to initiate ILM peeling. Catching the forceps midway and then start to grab the ear, grabbing nothing and going down step by step very slowly until grabbing the ILM. This helps not to injure the retina. Grabbing the ear is better than catching the retina and injuring the retina. When we are near to the retina, then start to elevate the ILM. After grabbing, we just move the forceps and observing the behavior of the retina. If the retina is moving with the forceps, this means that we are grasping the neurosensory retina, so we have to stop and going up. But if the retina is not moving, this means that the ILM is just gripped and we can now move and initiate ILM peeling. Always remember while ILM peeling is that the macula is concave and not flat. So when moving the forceps, we have to move the forceps slightly coinciding with the concavity of the macula and not perfectly tangential, otherwise we will hit the retina. The traction forces of ILM has to be done centripetal, directing the ILM peeling from the periphery towards the center of the fovea, not the reverse. If the reverse is done, it will increase the size of the macular hole, and this is not good functionally. When we are doing ILM peeling, we always focusing on the point of catching the ILM with the forceps. But otherwise, we have to focus also on the point we are going for, because the forceps may hit the retina at a far point, while we are not seeing or looking at this point. Finally, a 2-disc diameters of ILM peeling is accepted. We are not in need to make ILM peeling fully until reaching the arcades. Peeling of this area reserve a much more ILM if the procedure is failing, and we have to do inverted flap technique, so we have a reservoir of ILM at the periphery. Staining with triamcinolone and then initiation of BVD. BVD alone can help the macular hole to heal in up to 60% of cases, especially in small one. Then initiating the ILM peeling, in this case initiating the ILM peeling with tin scrubber, and then going with the forceps and totally peeling the ILM. This is the standard technique for ILM peeling in small one, and this is the most popular technique, pinch and peel technique. Pinching the ILM, initiating the first cut, and then going with the forceps to peel the ILM in a centripetal direction. So what are the problems which may be encountered during the standard macular hole surgery? Problem 1. While doing BVD and going to the far periphery, peripheral iatrogenic breaks happened. To prevent this, we have to put in our mind that these patients have abnormal vitreoretinal interface, so the incidence of iatrogenic retinal breaks is high. To prevent this, always look while doing BVD to the behavior of the retina below the posterior hyaloid. This can be helped not to stain the posterior hyaloid with kinacort. so we can observe meticulously what's happening at the periphery of the retina. How to deal if this happened? Solving this problem is to stop BVD at the point of iatrogenic retinal breaks, and then shifting to shaving and then lasering the breaks. The second problem is difficult ILM visualization, in spite of staining with ICG or BBG. How to prevent this problem? At first, we have to know what are the causes of not to see the ILM. The first one is the ILM not meticulously stained. So, for better staining of the ILM, we have to wait for a time to help the stain to settle, and also we can make a fluid air exchange and staining in the air. The second cause is that the ILM is covered with something inhibiting the stain to reach to the ILM. This thing may be a layer of hyaloid or maybe a layer of epiretinal membrane. So we have to remove this layer, whatever it is a hyaloid or it is a epiretinal membrane, before initiation of staining and doing ILM peeling. Problem 3. Iatrogenic macular break during peeling. While peeling the ILM, and instead of pinching the ILM, there is a pinch to the retina making an iatrogenic hole at this point. First of all, don't panic. We have to solve this problem easily. We have to go for a far point and reinitiate ILM peeling, and then reaching with the ILM until removing the ILM over this point of iatrogenic hole. This will help the hole to heal completely, like the macular hole which is present from the start of the operation. If there is a difficulty to peel the ILM over this iatrogenic hole, and there is enough space between it and between the center of the macular hole, we can go for laser, but we have to choose a very low power and a very short duration to protect the center of the macula from creeping of the laser over a time. And thank you.